Welcome to the Health Links podcast, where we bring you conversations that empower healthier living. Hi, I'm DJ Thatcher, a paramedic and registered nurse and the host of Health Links podcast. In this episode, we're going for a deep dive into the most commonly sought after topic when it comes to wellness, and that's weight loss. And in particular, non-surgical weight loss. So it's the latest trends and the latest recommendations. We're joined by an expert, as we always are, and today we have Dr. John Cleek with us, who's a board-certified physician in internal medicine and obesity medicine. He's with Novant Health's general surgery and bariatrics. So, Dr. Cleek, welcome to the Health Links podcast.
Well, thank you. It's a pleasure to be here. Thank you for the invitation.
Well, great to have you. And I think you are the first guest we've had since Novant Health has come to South Carolina. We see those great purple signs all over the state, but
yes.
I guess in the last 18 months or so, they're a new player in the South Carolina marketplace.
Yeah,
so,
and trying to grow aggressively.
Terrific.
Very much so.
That's good. So there is no lack of interest or lack of information when it comes to obesity or weight loss. In fact, we always joke that the two most common things that are Googled or searched online are how to make more money and how to lose weight.
Right.
And for most people, it's the opposite.
That's right.
They lose money and they gain weight and so forth. And so, in general, how big an epidemic is being overweight or obesity, coming from a physician standpoint?
Well, coming from a physician standpoint, if you look at the most recent CDC data, by 2030, 70% of the country will be overweight or obese.
Wow. Now, there's a difference there, too, because I guess for many of us, our definition is how we look in the mirror.
Right.
So, I'm a little pudgy, or, oh, man, I'm obese. So from a medical definition, what is overweight, and then where do we cross the line into obesity?
Well, unfortunately, we're using a marker called BMI, body mass index, which is simply your weight divided by your height in a formula that then gives us a number like 25 or 30.
Right.
So normal weight is considered 25 or less.
Okay.
Overweight is considered 25 to 29.9.
Okay.
Obese is 30 and above.
Okay, so fairly easy numbers. So your BMI, 25 and below, you're good.
Yep.
25 to 30, hey, do something. 30, worry.
Yeah.
So, or really do something.
That's right. And there are lots of BMI calculators online that are easy to use.
Yeah. I'm curious. I've got this smart watch, as many of our listeners do, and it has that BMI function. I mean, how accurate are these types of things? I've got to put my fingers on the buttons and hold my arms up and, make sure that I've not had a lot of water or that sort of thing.
Right.
Fairly accurate, or
fairly accurate.
Are they? Okay.
Yeah.
Okay.
Yeah.
Well, I'm in pretty good shape according to my watch.
So
good, I don't know.
Good.
We'll see. But who knows?
So the BMI, though, unfortunately, doesn't take into account body composition.
Yeah.
So if you're a very muscular guy, but only 5% body fat, you're still going to have a high BMI, but truly not be in danger of related comorbidities but from the fat. So BMI is great in a population when we look at the U.S., for example, but it's not as good when we look at a single individual. It has to be interpreted with a grain of salt, if you will.
So a big difference between the 250-pound jacked athlete full of muscle who's in top shape versus the 250-pound couch potato who doesn't move. Okay.
That is very much what
weight,
I'm saying. Same weight, but different composition.
And the composition of what? Muscle, I know, is obviously it's
muscle,
it
water, fat.
And then fat, right.
Yeah.
So they both obviously contribute to that.
Correct. Yeah. And so what we do is use one of the scales that uses a small electrical current called bioelectrical impedance, and use that to see what the percent body fat is and the muscle mass is. So we can really get a better understanding of does that BMI really mean anything?
I see. Okay. So now, as we seek information, there are gurus everywhere. So on the internet, on YouTube, and hey, they might be very knowledgeable. We have non-physician, whether it's gyms or fitness centers, that are providing recommendations. Obviously, physician-based, like yours is.
Yes.
What are some of the common themes among all of these people? Is it, calories in, calories out, eat less, move more? What are some of the commonalities among all these recommendations?
So the most common thing is just what you said. People try to apply the laws of physics or thermodynamics to this, where it's calories in and calories out. And if you have more calories in than calories out, you're going to gain weight, or other way around. Unfortunately, it's not that simple. Part of it is where are the calories coming from. Okay. Your body processes sugar much differently than it processes protein, for example. So it's not as simple as just calories in and calories out, unfortunately.
Gotcha. Yeah, there seem to be a lot of both recommendations and debate with weight loss. One of those is to focus on weight, weigh yourself every day, and focus on the BMI. Another school of thought is to forget about that stuff and really focus on things such as the insulin level, the cortisol levels in our body, and so forth. And what would your recommendation be? Or maybe, first of all, what is the difference in those philosophies?
Well, the difference in the philosophy, for example, is weight is just one measure of your health, not the measure of your health.
Okay.
So we can tend to get too wrapped up in what the scale says. Oh, I'm up a pound. This is a terrible day.
Right.
Or, hey, I'm down 2 pounds. Yay, me. And so we don't want to get so wrapped up in the scale as the only measure. Now, having said that, if we look at maintaining weight loss, say you've lost 15, 20, 50 pounds, one of the predictors of keeping that weight off is weighing on a regular basis.
I see.
In fact, weighing daily. Okay? On the flip side to that, we can look at hormonal changes, which is what I think we need to be more focused on, is the metabolic consequences of the fat.
Okay.
And see where that is going. So specifically, we look at other comorbidities like hypertension. What's your blood sugar doing? Are you pre-diabetic? As you say, do I have insulin resistance? What does my insulin level look like? What is my cholesterol? All of those things are impacted by weight.
I see.
And so we got to look at those more than the scale.
Sure. It might be good for the audience too. I think a lot of people are seeing topics like insulin and cortisol. They don't really know what it means. So what do those two substances, for example, do in our bodies, and why is that something we should maybe focus on as well when it comes to keeping weight off?
Well, so cortisol is the stress hormone.
Okay.
So when we're stressed, we make excess cortisol.
Okay.
From a weight perspective, though, it tends to make us want to eat foods that are high in sugar and often
food.
often processed foods.
Right,
as well.
right.
So we get extra calories in. And if it's sugar calories, we'll put a little more of that in the belly. So we're going to have a little bigger belly from that.
I see. Okay.
So stress management has to be part of controlling your weight.
That makes sense. I mean, is that something maybe a person should focus on first if they're stressed, they're not sleeping and things like that? Is it even worthwhile to focus on these other things before we get that under control, because their cortisol level is going to be so high?
Well, and sleep itself is a whole nother area that we focus on, because it's critical to controlling weight.
Okay.
When you don't sleep, even one night, you only get 5 hours or less, the cortisol goes up, the insulin goes up, and again, we end up eating excess sugar calories typically because it gives us a quick energy boost.
Okay.
So long-term sleep disorders then are associated with causing obesity by also changing a hormone called leptin, which tells the brain how much fat we have.
Okay.
In this case, poor sleep, the leptin goes down, saying we don't have enough fat. And so we got to make more.
Okay.
So long term, it also causes persistent weight gain.
Gotcha.
So the ideal is 7 to 9 hours of sleep a night.
Okay, guilty. I'm not getting that. All right, that's another topic. That's another topic. On our previous podcast, we discuss regularly the fact that South Carolina is at the top or right near the top of a lot of things we don't want to be.
That's right.
Heart disease, obesity, renal failure, dialysis, etc.
Right.
And I imagine that a common link among all of those is obesity, which is driving some of that. Is that a fair statement?
That is definitely a fair statement.
Okay. And,
remember, obesity, especially carried in the belly, causes inflammation chemicals or hormones to be released. And those inflammation hormones create the arterial blockages that create stroke, that can create kidney disease, heart disease, also predispose you more to the diabetes, which again affects all those cardiovascular outcomes.
what do you think the root cause is of obesity in general? I mean, we have more people alive today than ever in the history of the world. We have more technology, more information, and yet arguably we are the unhealthiest we've ever been as a people. And what do you think some of the biggest root causes are of obesity?
Well, I think one root cause is the food that we have.
Okay.
Right? So back in the early 2000s, in 1 year, there were 20,000 new foods introduced. Now, I don't know about you, but I don't know any new vegetables or fruit. So those are all processed foods.
Right.
And so processed food is one of the big triggers, especially ultra-processed foods, for obesity. So I think that's one thing. And we've come to rely more and more on those, right?
Well, we're busier. We grab food.
We grab, put it in the microwave, have dinner in 2 minutes, and go on.
Okay. There are a lot of foods, I guess, especially I think carbohydrates, carbs are often implicated, that you eat these things, you get satiated, you get that sense of, hey, this tastes really good. But an hour, 2, 3 hours later, you're looking for another meal or another snack. Is that truth to that as well?
That's true. One of the things when we go back to talking about stress and weight, right? When we're stressed, it starts to delete some of the neurotransmitter levels in our brain. Like dopamine, serotonin, which is associated with depression when it's low, that type of thing. And carbohydrates, especially the more sugar content, replace those temporarily.
I see.
So the carbohydrates make us feel better.
But they wear off?
And then they wear off. And then, I liked that feeling. So there really is a potential addictive behavior to the sugars and carbohydrates.
Wow. All right. So you're part of Novant Health's general surgery and bariatrics. And first of all, what is bariatrics? It sounds like it's related to the weather, but I know it's not. What is that?
Bariatrics is actually the surgery procedures associated to help reduce weight.
I see.
Mostly the sleeve gastrectomy and the gastric bypass or Roux-en-Y gastric bypass are the two most common procedures.
I see.
Part of bariatrics.
And obviously your practice offers that, and your specialty is on the non-surgical side of that. So,
that's correct.
So I'm coming to you, I'm overweight, I think maybe I'm even obese, my watch is blowing up telling me so. What's the first thing you do when you evaluate a new patient? What steps do they go through?
So when a new patient comes into the practice, actually the first thing we do is measure their metabolism. See what their metabolic rate is like.
How's that done?
And that's a simple breathing test. It takes the oxygen from the air, the room air, and then when you exhale, you breathe out oxygen along with carbon dioxide. But the difference between room air and what you breathe out is how much oxygen your body has used.
Makes sense.
Based on that, it tells us what your metabolism is.
Interesting. And a normal metabolism rate would be what? I guess probably some complicated scale.
It varies for age and gender and weight,
Okay.
and everything else. So,
Okay. So you say to me, okay, DJ, man, these numbers are off the wall, whatever.
yeah.
I'm borderline obese, perhaps. What steps do you go through next then?
So the next thing I do is go through all the health history.
Okay.
I am an internist by training, so I got to do all that as part of the makeup. But again, we're looking for obesity comorbidities.
Mm-hmm.
Well, how is your blood pressure? Are you hypertensive or pre-hypertensive? What's your sugar? What's
see.
your cholesterol? Do you have a sleep disorder like sleep apnea? All those kinds of things. What are your stress levels like?
Okay.
Go through all of those so we can see what the trigger may be to the weight.
Well, it's a big advantage to going to a physician as well, because you can address those if it's a diabetic problem
Right.
versus a sleep disorder or something like that. So
That's correct. And usually they overlap, quite honestly.
I see.
It's usually not just one when I see people. The other thing we do when they first come in is start using that scale I talked about to look at body fat percentage
Okay.
and muscle mass. So we can follow that serially as we go along.
I see.
So we can make sure we're losing fat and not so much muscle.
Sure. Obviously, the first rule of medicine is first do no harm, and
Right.
so I'm sure you start with the most conservative treatments first. I would imagine. What would those
Right.
be? Like the typical diet, exercise, or
So
what?
conservative or baseline, no matter whether you do medicine or go to surgery, you can eat through anything if you want to bad enough.
I see.
Okay?
Yeah.
So the first thing is lifestyle modifications.
Okay.
And that includes nutrition, physical activity, fluids, right? Stress, sleep, and mental health.
Maybe drink more, eat less.
Yeah.
But it's fluids, not alcohol. Maybe, yeah. Okay. I got you.
So we have to go through those 6 foundational issues.
Okay.
To evaluate the patient.
I see. Okay.
And then I tend to start with, on lifestyle modifications, a slightly higher protein, a little lower carbohydrate meal plan.
Okay.
One of the things we know, especially in this era of GLP-1 treatment, is we have to get enough protein in to minimize muscle loss.
Okay. Makes sense.
And that's true in post-operative patients. They have to get the protein in. So we really focus on getting protein at every meal.
Okay.
And a typical protein goal would be about 1 gram for every 2 pounds of body weight.
Okay. I've heard 1 to 1. I've heard 1 to 2. So it's good to get an
Roughly,
expert opinion.
yeah.
Good.
Well, roughly that.
Yeah.
Some recommend higher. I think it gets really difficult to get higher amounts in.
Sure.
The saying is the best diet is the one you can stick to. So we can't be too restrictive on the flip side with the carbohydrates, right? So I still allow a carbohydrate at each meal if you want it.
I see.
You don't have to have one.
That's nice to have that option, though.
Yes, it is.
Going back to protein, there's a lot of debate about what's recommended. So we have obviously meat directly from meats and eggs and things like that. There are the powders. There's whey protein. There is animal-based protein. Is there a difference among any of those, or if you get protein, it's protein?
Well, so first of all, I like protein from whole foods when we can, instead of some processed protein.
Okay.
So first, if we can get it through meat, eggs, dairy, beans, tofu, that's great.
Okay.
But if we're not able to do that, or it's a choice between having a protein supplement or skipping a meal, I want the protein supplement.
Okay.
So when it comes to protein, the best protein is whey protein.
Okay.
Which
is usually plant-based, is that right? Or
no,
that's not.
this is
It's
from
not.
milk.
This is the gotcha.
Whey protein is really the best.
Okay.
And you want whey protein isolate. That way it's not with a lot of other additives.
Write that down. Okay.
Okay.
Gotcha.
So Now, the problem with that is if you were watching the news this week, Consumer Reports just showed that most of the protein powders have too much lead in them.
Mm-hmm.
So we've got to be careful about which protein powder we look at.
Well, it's like anything. You talked about the 20,000 new foods. Most of those
Yeah.
are supplements or additives, rather.
Right.
And we see that even on seemingly healthy foods, a lot of
Correct.
additives and fake sugars and whatever else to make
That's
it taste
correct.
better, I guess. But
Mhm.
it's a problem.
That's right.
Okay, so you make these recommendations to people. Are you feeling under pressure as a physician to prescribe something? I mean, people go to a doctor and they want to leave with something they can take or something that's going to give them an immediate
Mhm.
effect. And, we're inundated. The U.S. and New Zealand are the only two countries that permit pharmaceutical ads for prescription drugs right to consumers.
Yeah.
I saw a birthday card recently. It was pretty funny. It said, I hope your new year makes you as happy as all those people in the pharmaceutical commercials. they all look
Yeah,
happy and
they
thin
do.
and everything. But do you
Yeah.
feel some pressure that you have to go right to a medication or something like that?
No, I don't know that I feel pressure.
Mm-hmm.
But let's be honest, most of the people who come to me have tried 5 or 6 different things
Okay.
already.
So sure.
So we've already proven that they can't lose weight with some lifestyle change by
Mhm.
itself.
Okay.
So I'm a little more quick in those people to use medication.
I see.
Now, if you've never tried anything, then yes, let's try lifestyle.
Okay. Makes
But
sense.
but unfortunately, if you look at lifestyle by itself,
Mhm.
the average weight loss is about 10% of your body weight.
I see. Okay.
So that's fine if you're 200 pounds and want to lose 20 pounds.
Right. Mhm.
But if you're 300 pounds, are you going to be happy at 270?
Right. Yeah.
Probably
Yeah.
not. Right?
That's true.
Now that 10% will make significant health differences in blood sugar and cholesterol, but it's not going to really be satisfying for the patient.
That's a good point too. Somebody who is morbidly obese, and
Mhm.
maybe they are 300 plus pounds, what's a realistic end goal for them? They're not going to get to 175, are they? Or without surgery? I don't know. Is there a realistic percentage that your body just kind of stops at?
Well, we're limited by our physiology at this
Okay.
point. So currently, if we talk about the newer medications,
Mhm.
then we're talking about a 20% body weight loss on
Okay.
average. Okay.
Pretty
So
significant.
300 to 240.
Big difference.
Okay.
Yeah.
Surgery is about a third of your body weight.
Wow. Okay.
Okay. So 300 to 200.
Mhm.
So surgery still has better outcomes at this point than our medications do.
Okay.
And appear to have better long-term results. But we haven't had the newer medications long enough to really know
I see. Okay.
that.
I know a lot of patients who come to you are probably pre-op. They need a knee replacement or
That's
a hip
correct.
replacement because of that weight. It's causing
Mhm.
damage to their bones. And so
Mhm.
in order to succeed in those surgeries, though, they need to bring their weight down. And so are those people that you might tend to go to a medication or maybe even bariatric surgery before they get their joints replaced?
Yes,
No, okay.
that would definitely be true.
I see. Okay.
The thing you have to realize is their limited mobility does impair their ability to lose weight.
Mhm.
But on the flip side, when we talk about weight loss, 80% of weight loss is based on what you're eating.
Okay.
Only 20% is based on your activity patterns.
Mhm.
So we can still help those people lose weight and get to that surgery.
I see a lot of recommendations are based around two things. One is, hey, don't worry about going to the gym and doing some major workout. Just walk,
Mhm.
especially after meals and at particular times. And then the other is the whole concept of fasting. And you see recommendations from anywhere from 12 hours to 5 days
Yeah,
to take a
yeah.
fast. I mean, what are some of the truths with both of those as far as just, hey, maybe walking versus heavy exercise, then also any fasting recommendations that the people might be interested in?
Yeah. So first of all, the philosophy of an exercise is sort of like the one on meal plans. For you, it has to be what you can live
What
with.
you'll do.
Yeah,
Okay,
right?
I got you.
Right. So if you hate going to the gym, telling somebody to go heavy workouts at the gym isn't going to matter
I
because
gotcha.
they're not going to do it.
Sure.
So The thing I like about walking simply is it only requires a good pair of shoes, right? So the investment is not as big for somebody to start with an activity program. The other thing I recommend is once we've started walking a little bit, we try something that's called Japanese walking.
What's that?
And Japanese walking is you go 3 minutes at your regular pace, and then you go 3 minutes at a faster pace.
Okay.
And then back down, and every 3 minutes.
It's like some interval training
It's
almost.
an interval training.
Yeah. Makes sense.
And that does better for calorie burning, lowering blood pressure, controlling blood sugar, etc.
I see.
So
Okay.
that's an easy way to pump up, if you're already walking a little bit, to pump up the intensity.
Sure.
Yeah.
Then we talk about fasting. I know the longer we fast, the more our body engages this autophagy, or it begins to eat its own fat as a fuel source. What's a good recommendation here that people might actually stick with? Anything that you've seen that is a sweet spot for fasting?
The studies on fasting are so mixed
Okay.
that I'm not a big proponent of fasting.
Period.
I
got it. Okay.
One form of fasting is you fast 2 out of every 5 days. Another form is not eating for 16 hours. You only have an 8-hour window.
Sure.
Again, the only thing it's shown is it reduces total calorie intake, but it's beyond that, it doesn't have necessarily any special significance.
I see. Okay. All right. We'll take that for what it's worth. There's a lot of information out there.
Yeah.
So going to the medications then, which is probably a lot of what people are interested in with having you here as a guest today. So we have the GLP-1 medications, the Ozempic, and others. What are some of the pros and cons with those, or when would you maybe lead with those as a physician?
So the newer medicines, which for weight loss would really be Zepbound or Wegovy as the injectables, are really a breakthrough in the last 3 or 4 years.
Okay.
It's the first time we've had medication that makes a significant impact on weight, to be honest.
Good. Okay.
So I tend to use those first and foremost when it's feasible. And by feasible, I mean 60% of insurance companies cover it, but at least 40% who don't.
That's a whole nother podcast about that.
Yeah,
why aren't they paying?
Saying,
Right. We get
and
that.
most people can't afford $500 a month.
Wow.
Which is what the out-of-pocket cost would be.
Yeah.
So there's still too many limitations or barriers that I can't get a lot of patients, especially the Medicaid and the less financially well patients, to get.
Okay. Well, that's a big downside.
Yeah, so that's a big downside. The plus side is it's really interesting that the GLP-1s in the brain tell us we're not hungry.
Interesting. So that's how they really work then.
Well, it reduces appetite. It also reduces what we've come to call food noise, which is the thinking about food.
Oh, okay.
Like patients who, I'm having breakfast, what am I going to have for lunch?
I see. Okay.
That kind of thing. Or what am I having
there, done
for
that.
Yeah, what am I having for dinner?
Okay.
And it reduces that compulsive thinking about what am I doing next.
Interesting point. I hadn't thought about that, yeah.
The other interesting point is that they seem to help addictive behavior.
Okay.
So we talked about carbs and the change in hormones and neurotransmitters in our brain. So this helps reduce that addiction as well. It's been shown to reduce alcohol use. They're looking at it for cigarette use.
Interesting.
Etc. So paradoxically, it may be part of that effect as well. Yeah. In the stomach, it slows how quickly food empties. So we stay full longer.
That's satiation, as they call it. I got it.
Yeah. So we're less hungry, we're satiated longer, so we eat less. And that's how they work. Now,
that makes sense.
Yeah, the most common side effect are stomach-related, nausea, diarrhea, interesting constipation, and heartburn or reflux.
Okay. All right.
Would be the most common things.
There's
we
a
see.
give and take with anything. Yeah, we
Yeah,
get
that's right.
that. Some of the criticism of this class of medications is that, yes, you lose weight, but you not only lose some fat, but lose a lot of muscle with it too. Is there truth to that, or with these newer drugs, has that been addressed?
Well, again, that goes back to that base lifestyle modification and getting your protein in.
Okay.
Yes, if you don't get your protein in, you can lose excess muscle with any meal plan or any diet that has relatively rapid weight loss. So it's not just an effect of the GLP-1s.
I see. Okay.
It's the effect of the rapid weight loss.
So it's got to be a total package. You just can't
That's
take
right.
a pill and expect things to.
Yeah, and we learned
change.
that from surgery too.
Right,
Because if we don't focus on protein after surgery, they can lose too much muscle.
Yeah.
Because they're losing weight rapidly.
Sure.
So it's got to make sure we do that. And if we go back to exercise for just a minute, that also means we need to do strength training 2 to 3 times a week.
To maintain the
the muscle.
Sure.
Right? Because if you lose muscle, you slow your metabolism.
That doesn't have to be like the jock kind of thing,
Oh,
lifting
no.
barbells. It could be something relatively simple. Is
That's
that
right.
Okay, that makes sense. As we finish up here, here's an analogy for you. You know, in the legal field, a lot of people talk about prisoners and prisons and so forth, people who are released from prison. And the latest stats are it's about the recidivism rate. About 70% of prisoners who are released from prison, they get rearrested within 5 years.
Right.
And so now the analogy here is, what about people who are on these medications? Are they on them for life, or do they come off them once they lose weight? And if so, what's the recurrence of gaining weight again? I don't know if you have any stats on that or not.
So the only thing I can say is, first of all, they did a study stopping the medication after 6 months.
Okay.
And you regain 2/3 to 3/4 of the weight pretty quickly.
Wow. Okay.
Okay. So we know that that's not a strategy that's going to work. Right. They just stopped it cold turkey. Okay. So the question is, if we do it longer, can we taper off? We don't know. We haven't done that study. I approach patients and saying this may well be a lifelong treatment. We don't have that answer, or at least as long until something new comes along. Right? Because there are so many new drugs in the pipeline. There are going to be 3 to 5 medicines coming out in the next 3 years.
Good. Okay.
So we're going to have some different alternatives. So hoping that will help as well.
Terrific.
But for now, I would presume it's going to be lifelong.
Gotcha. All right. Well, Dr. Cleek, any final words or recommendations for our audience as we wrap up?
I'm just a believer in common sense. And I think
we need more of that.
I think that's how we need to approach this.
Sure.
Right? Well, it can't be a meal plan that eliminates a whole category of foods for the rest of your life. Because if you don't, you're just going to put it back on.
Sure.
Exercise has to be the same way. Right? We can't go do all those heavy workouts for 3 months, lose some weight, and say, okay, I'm done.
Gotcha.
Right? So it's finding that sweet spot of what we can do long term. And that's really the bottom line.
Makes sense. Well, we're speaking with Dr. John Cleek, who is with Novant Health's General Surgery and Bariatrics program about non-surgical weight loss. And you can get more information at novanthealth.org. And Dr. Cleek, thank you so much for joining us here on the Health Links podcast.
I appreciate it.